Welcome to the 5th annual meeting of the Northwest Precedent Practice-Based Research Network. I'm Tim DeRouen, co-director of the network, chair for the network. So what's our status? Membership-wise, we've had almost 350 members who've signed up and are eligible to participate and have undergone some training or kept in touch with us, we call active members. Of those, 205 of you are fully trained, going through all the training, and so you're eligible to participate in enrolling patients in your offices. So in that 205 fully trained members includes 160 general dentists, 42 orthodontists, 3 pediatric dentists, and 16 community clinicians. And as somebody pointed out this early in the morning, those numbers don't add up to 205. And there was a dentist who, I should point him out. It was a dentist who pointed that out. Actually, that's because the 16 community clinicians are in other categories as well. Most of them are general dentists, but I think there may be a pediatric dentist in there. We also have the category of friends of precedent, people in other states or specialists who are not eligible, and we have 153 of those. So depending on who you're counting, we have somewhere between 205 to almost 500 members of various categories. This is the distribution. These are just the general dentists, but this is the distribution over the geographical area that our network represents. So as you might expect, they're clustered like in Seattle and Portland, but spread all over the place in the others as well, which is good. Just quickly giving you an overview of where we stand on studies. We've now completed 5 studies. The first one we did, the Oral Disease Indicator Survey, it seemed like it took forever to get it going, and it went on forever, and it actually started in 2006, and we shut it down in last summer in 2009. We got 101 practitioners to participate with 1,943 patients, and so we have a pretty good snapshot of your patient population, your patient visits. And there have been publications that have come out now on that. We have, well, not come out, but they will be coming out. We have one in JADA that'll be coming out relatively soon, giving the characteristics of the network. Others in community dentistry and continuing education that will describe certain aspects of that study. We've completed Study 7, which was a survey of treatment of dentin hypersensitivity in practices. We started that in December 2008, and we finished it in June of 2009. We had a goal of enrolling getting 200 dentists to take the survey. We got 209. So we're pleased with that, and the results of that study are actually in press. They'll come out in JADA soon this year. We participated in 3 studies with the other 2 networks in an organization called Condor. We did a case control study of osteonecrosis of the jaw. It started in 2007, completed enrollment in the fall of 2008. When we went in, our enrollment goal was 135 cases and controls. We actually ended up contributing 206. We recently had at the AADR meeting last week in Washington, D.C., the 3 networks put on a symposium giving the results of that study, and there's a manuscript in preparation which should be submitted for publication soon. The other 2 Condor studies, we participated in 2 surveys. One was one on the impact of dental practice-based research networks on patient care, and the other was advancing primary care management for TMJD. Those 2 surveys we completed this past year. The last one we started one of them in June, finished it in October. I think it was the most recent one. Gives you some, well, not the most recent was the TMJD one. But in both cases, we're able to go in and do a survey. Our goal has been around 200 practitioners. We're getting over 200. We had 207 participated in the PERG study, 228 in the TMJD study. And we're getting to the point where we can do a survey beginning to end in about 4 months, turn it out, and then write it up. So we're getting to be somewhat of a well-oiled machine on doing especially surveys. We have several active studies ongoing, in fact 7. Now last year when we were meeting, we were talking about what we were going to be doing in the future. And I think we may have even presented a slide, but we were looking at starting several studies. And some of you may have wondered if we were going to really do that because it had taken so long to get to the point where we're getting studies out. We have done that. We have all these studies out, and some of them are going quite well and are getting close to being fully enrolled. So the study 2 on the salivary markers and caries risk assessment had been underway for some time. We have a publication coming out on it on reliability studies we had to do on some of the salivary tests. The Carl study on relaxation learning is still ongoing, but it's going to close in a couple months if you have patients you'd like to enter into that. The study on outcomes of cracked teeth is going well. There's a publication in press already on review of the literature for that, and you'll hear more about that later. Study 6 on a randomized trial on MTA versus calcium hydroxide and direct pulp capping. We have a publication out on a review of the literature in operative dentistry, and you'll hear more about the enrollment in that in a few minutes. Study 9 on third molar extraction is underway and going well. Study 11, temporary anchorage devices in orthodontic practice, it's ongoing. Enrollment's a little bit slow, but we're going to talk about it with the orthodontist today. And a new one that's just starting up, remineralization of white spot lesions after removal of orthodontic brackets. It's just getting underway, and our keynote speaker today is going to speak about remineralization, so it's a topical study that we're going to be addressing during the day. Some studies to be launched in the coming months. Prevalence of hypersensitivity in Northwest precedent patients. The study we have planned is probably going to be initiated late summer, early fall. It's going to be a quick one. We're going to ask you to go in and at a certain period of time examine like 30 patients in sequence in a relatively short period of time and do a relatively quick examination for dentin hypersensitivity. So it'll be one that'll be relatively easy and quick to be done. Study 16 on genetic factors and caries risk assessment. We talked about last year about doing this, and Bob Wyant, who talked at the meeting last year, is here again because we're about to launch this study. As soon as we get IRB approval for it, we have everything else in place. And again, the ones eligible for this would be the practitioners and the patients who are participating in study 2 on salivary risk assessment, and because we're going to approach them at a follow-up visit to see if they would be willing to participate in the genetic test, in giving a salivary sample for genetic testing, with the stipulation that whether they participate or not, they continue in study 2. So it's completely optional whether they participate in this study. And finally, a study to be launched in the coming months soon. It will be a survey of attitudes and beliefs of dentists concerning treatment of patients with special health care needs. And this includes patients with severe chronic diseases, not just a very narrow definition of special health care needs. We're doing this, and I want to make a plea for this. We would like broad participation because we want to look at what issues there are about access to care to understand what the issues are about treating these patients as far as practicing dentists. So we need honest and accurate information in order to develop programs aimed at increasing access to care for this patient population. The executive committee endorsed this study because we believe that in this network now we have sufficient trust of the members that we can obtain high participation levels and honest and straightforward responses, which is important. And to make sure your responses to the questionnaire, some of this is not going to be that sensitive, but some of it may be sensitive. We're going to decouple your identification from the responses. We'll only track whether you've participated. So if we contact you again, it means we just know you if you haven't filled out the questionnaire, but we're going to decouple your identification from all the responses. So it'll be launched soon, and I really encourage you to participate in this because I think there aren't very many situations in which you can get this kind of valuable information. So what I'd like to do now is turn the podium over to Dr. Don Dinucci, who's our representative from the National Institute for Dental and Craniofacial Research. Don.
Just want to thank all of you for attending this important meeting. I'm always so delighted to see the participation here at Northwest President. As you probably remember, it was about a year ago that we met, and there was some concern about the numbers of studies that you had ready to launch and whether or not, you guys could meet the challenge. And I was very confident, but believe me, there were a lot of folks who thought that couldn't be done. And I think what you're demonstrating now is that you are able to meet that challenge. And I'm just so delighted, so I want to congratulate all of you on that. And of course, encourage you to continue to enroll and participate in the studies, because this particular project is all about practicing dentists. You are the most important asset in this whole process. Let me explain a little bit before I get into the presentation. You can see I'm from NIH, and I want to explain somewhat about the government hierarchy. These are just, for many of you, these are just these are acronyms from Washington, D.C. But you probably know that the Health and Human Services is a cabinet-level agency. Everybody knows that. And under that, then you have the NIH. And within NIH, you have about 33 institutes. And one of those institutes is the Dental Institute, or NIDCR. Our budget is about $400 million. That's with an M, not a B. There's a lot of B's out there, it's $400 million, so it's quite small, actually, compared to the budget of the entire NIH. And of that particular $400 million, we've invested $75 million over 7 years in practice-based research, in investment in actual practicing dentists. The NIH doesn't really invest in practicing physicians, so this is very unique in some way. Now, there is one other very small agency that's part of Health and Human Services called AHRQ. That's the Agency for Healthcare Research and Quality. They're kind of a watchdog agency. Their goal is to make sure that quality care is provided to the American public. Their budget is extremely small. They do have PBRNs. Physicians actually are involved in those, probably about 50, I would guess. They're not well funded. They're provided with seed money, and then they're told once they're up and running, they have to seek funding on their own. So this is a very unique situation where we have a lot of upfront funds available to really establish the infrastructure for an enterprise like this. Now, some of you, of course, have been here year after year, and you've seen some of these slides, but for those who haven't been here before, I'm going to give you a little background on the whole process. This is practice-based research, is what we call real-world evidence for the prevention and treatment of oral diseases. And the whole purpose is to answer questions that you face in the daily treatment of your patients. I was a clinician for 35 years, and there are always questions arising when you treat patients. What's the best thing to do in this case? So this is what this is all about. It's to answer those types of questions. And there are many ways that can be done. Some of the questions clearly can't be answered. You probably have discovered that already, that some of you have had good research questions that just cannot be answered regardless of how it's done. It's very difficult. But for those that can be answered, that we think can be answered, we have observational studies. You've been engaged in that. We have clinical trials. We're finding out that those are very difficult to conduct in practice-based research networks. And actually, most of the medical PBRNs don't do randomized controlled trials simply because they're so difficult. So you're taking on some real challenges here, and you're doing very well. The other piece to this was to establish a flexible and adaptable electronic platform that allows connectivity between the practitioners and the data coordinating center, Axio, and so forth, so that you're transmitting your information electronically. And that will probably in someday support or enhance the deployment of some form of electronic health record over the next several years, which is probably going to be a reality, certainly for medicine and eventually for dentistry. So the objectives then were to conduct a series of studies over these 7 years, and you're well on your way to doing that, with an emphasis on oral health treatment, diagnosis, and prevention. And we wanted to make sure the outcomes of these studies were meaningful to you, something you could take home and apply, not something that was kind of esoteric, that didn't have good translational strength. We wanted something that was clear and meaningful. And then also, the PBRNs have also the potential to serve a surveillance function. And I think I don't need to explain what that is, but certainly there are some less frequent conditions out there that you may be seeing in your offices. You could be reporting on these, and these responses could be collated, and I think that would be very interesting information. So again, I want to emphasize that these PBRNs draw on your insights and your insights help and experience help frame the questions. And what you're seeing here today is this kind of partnership that you have with your academic colleagues, and that's very important. And then we get this rapid translation, hopefully, into clinical practice. And there's some thought that this may actually be a more cost-effective means to conduct research. As you probably know, the translational piece, moving evidence into practice, has always been a challenge. Some of you have probably seen the quote that it takes about 12 years for a study results to actually make it into clinical practice. Probably a little bit less than that. We're hoping that maybe we can reduce that to a few years. Just give you a little background. These were established as what we call cooperative agreements. They weren't a grant per se where the money is just simply provided to the entity and then the NIDCR walks away and comes back 7 years and hopes that something's been done. So that's why I'm here today, and that's why I attend your meetings, and I'm engaged almost on a daily basis with everything that's done with the practice-based research networks. And as I said, $75 million over 7 years. We have 3 awardees. This endeavor began in 2005. We have the Pearl Network, which is administratively based at NYU. We have the DPBRN network, which is administratively based at Alabama and Florida. And then within that, we have the Permanente Dental Associates, Health Partners, Georgia, Mississippi, and even a Scandinavian component. And then, of course, Northwest President here, Washington and Oregon. And then we have this trans PBRN entity that Tim mentioned called CONDOR, which is an acronym for Collaboration on Network Dental and Oral Research. And you'll probably see along with that CONDOR, there's a logo, a large red condor. And that was developed by Justin. So I told Justin the condor continues to fly on. But so if you see Justin, thank him for that. Presently in year 5, we have certainly over 700 practices participating within the 3 networks. And we have a relatively diverse geographic locations for these practices. However, you can see on this map, there's still a lot of white. These are areas where we haven't really made inroads. So there's more to be done. Just going to give you a little, we've got 2 of outstanding practitioners here, one from Pearl and one from DPBRN, and they're going to really discuss this in detail, but this just gives you a little idea of the types of studies that are being done in the other networks. And then, of course, here's your network, and you're very familiar with these studies, of course. Now, also, one of the things to keep in mind as we move forward in this new era of healthcare is that it's important to think about studies that we might be able to do that would help us collaborate with our medical colleagues. So Pearl is doing a study that's looking at analgesic prescribing practices of dentists, and they're going to be linking up with a medical PBRN to see how physicians prescribe analgesics for various conditions and then kind of compare the 2. I think that's going to be very interesting. They're also looking at xerostomia and then also drug and alcohol counseling, which is really opening up a completely new area in dentistry, and we're not really sure whether dentists actually want to get involved in that. So we'll see. DPBRN, doing some glycemic screening in dental offices using glucometers, and involved in tobacco cessation. And then you have one study that I'm aware of. If I missed one that's more medically relevant, I apologize, but the one that I'm most familiar with is the computer-assisted program for needle phobia and anxiety management, which certainly would have applicability in medicine as well. And certainly all the studies that you're doing have some level of applicability, but these are the ones that I thought were probably the most illustrative examples. And then we have these collaborations. We have the O&J study. These are the so-called Condor studies. We're also looking at the impact of PBRN involvement on clinical practice and the practitioners. We really don't know whether it makes a difference in terms of clinical outcomes as to whether or not a practitioner actually is involved in this process. We think it probably does, but we don't know. So we're going to start to try to measure that in some way, see if it's actually making a difference. And then we have this TMJD survey to determine actually how dentists manage this condition in their practices. And this is going to be very interesting. There's almost no information on this at all in the literature. So here's the future then. I think it's important to note, and I'm asked this question all the time, will this endeavor continue after 7 years? And my answer is an emphatic yes, because this particular entity, the practice-based research, is included in the NIDCR strategic plan. That's the code that says basically yes, it's going to continue. So it's going to continue. So don't worry about that. We're going to build on what we've already invested in. It would be, I think, probably not prudent to say, well, at the end of 7 years, let's build something else completely different and goodbye to the practitioners. That would be, I think, inappropriate. So we're building on what we've done, and we hope that all of you, choose to be part of that as we move forward. We're still in the early planning stages, so that's about all I can say at this time. So again, just to reiterate, practice-based research networks conduct research in the real world of dental practice. They draw on your experience and insights, and they really do have the potential to change the way we practice dentistry and improve the care that we provide to our patients. But I want to reiterate, the success of Northwest President depends on you. So it's important today that you become engaged in the process today. I think what you're doing today, part of it anyway, what you're doing is looking at the practice models out there that might be most conducive to practice-based research. So it's going to be interesting. This is, I'm certainly going to be worthy of a publication. If you can determine what model of dental practice, what configuration is actually the most conducive to practice-based research, I think that would be a very interesting finding. So I hope you engage yourself in the activities today. I think that's very important. Okay, that's really all I have. I won't take time for any questions, but I will be meandering around today. So please don't hesitate to come up if you have a question, and I guess we'll turn it over to the next speaker.
Thank you. Thank you for having me out here. It's a great time to be here. Thanks to Don and the wisdom of NIH to support such a program. I think it's an innovative approach to the future, and I'm excited to be a part of it. Basically, on the plane coming out here, I was realizing you guys are extremely lucky because my mother left South Dakota in the late 30s and came out here with her sister and another lady and came to Seattle and worked as maids. And if the sun came out, she might have stayed and I might have been one of your brothers. But the sun never came out, so she went back to South Dakota, back on the prairie, and of course that's where originally I came from. But ironically, 50 years later, she was diagnosed with seasonal affect disorder. So anyway, again, the dental PBRN, and as you realize, our regions that is Washington, Oregon, which is a president group, Minnesota, which started out as Health Partners. I'm not a Health Partners dentist, I'm in private practice. When I joined the dental PBRN in Minnesota, there were 29 Health Partners dentists, And I would say we probably have close to 90 dentists right now because I got so enthused that I recruited a lot of private practitioners. So we had to change the Minnesota from Health Partners to actually Minnesota. It also includes Mississippi, Alabama, Georgia, Florida, Norway, Sweden, and Denmark. Why were these regions chosen? Looking for a diverse mix of practice types, diverse mix of philosophies, dentists from a diverse range of dental schools, which I think is extremely important. I went from the University of Nebraska and practiced in Minnesota, and there's definitely a different philosophy between the two schools. Regions with whom we can easily communicate, regions that administrate the infrastructure if possible, and patients with diversity in race, ethnicity, social economic status, geography, rural, urban, etc. Again, why? Alabama, Mississippi. Again, our network is based out of the University of Alabama, Birmingham, but it has graduates from the Southeast dental schools, good rural and urban mix. Again, to include the Black and African American diversity of both dentists and patients into the network. The Alabama folks already had experience in practice-based research around the smoking cessation issue. The advantage of having a coordinating center at the same location, again at UAB, and private practitioners involved in both states, and really only 2 practitioners in public health. The Florida-Georgia region, again, they combined with UAB, the University of Florida initially. But Florida is unique in the sense that it has graduates from the Southeast, but also has a lot of dentists from the Northeast dental schools. And a potential for a good rural and urban mix, a contribution to the Hispanic, Latino, and the Black African American diversity of both dentists and patients. Again, they had a history of doing practice-based research in the past. Again, private practitioners in both states, and 2 practitioners in public health. And again, they had an administration base at the University of Florida. Health Partners and Kaiser Permanente Dental Associates, and basically they already had groups that were organized, groups of dentists. They themselves, again, represent graduates from the Midwestern schools and the Northwest dental schools. And those groups of dentists meet regularly as part of their group. And again, it added a mix of practice types of managed care organizations and PPO type of practices. Both groups have already had a productive history of doing dental practice research singly and as together. The Minnesota region, like I alluded to, was called HP Minnesota because it was initially intended to only be the health partner dentists. And in a recruitment aspect of it, I was recruited, and being a past president of the Minnesota Dental Association, I got involved more or less out of skepticism, not out of belief, and I'm a true convert, and so I'm an enthusiastic promoter of practice-based research, and I do feel it's the answer of bringing our dental school education together with us practitioners to solve the patient problems and patient solutions into the future of better health. The administration base there is at Health Partners there in Minneapolis, and again, the Kaiser Permanente Dental Associates group, the PDA, have only the PDA dentists in the Washington, Oregon area. And again, the administrative base is there at Kaiser. The Scandinavian region, what a gift to have these included in our network. They come from a different perspective, but it has changed the way I practice dentistry, it's changed the way I talk to my patients. It's been a huge gift into our network. It creates an international mix. It brings in the Scandinavian Dental School graduate. The patient population is much more homogeneous than ours. Again, it contributes a mix of both private and public dental practice settings. Their settings over there, depending upon the country, is a huge amount of government-sponsored public clinics. Again, they have a long history of practice-based research, and the dentists include dentists from Denmark, Norway, and Sweden. And again, a good mix of private and public health administrations, and it's administration-based. The administration base is out of the University of Copenhagen. Again, what is our network about? As Don alluded to, it is for the practitioner, investigators, and for our patients. It's practical science done about, in, and for the benefit of real-world clinical practice. Hopefully, it'll improve us as dentists into the future. How many dental DBPRN members are there? As of January of 2010, we have 1,235 completed the enrollment questionnaire, which is, everybody, including our friends. 953 have completed one or more DPBRN studies, and 441 have completed one or more clinical studies that require human participant training or sign a kind of financial agreement there, which includes general dentists, dental specialists, and dental hygienists. As of February of 2010, the data collection has been completed on 10 studies, which include the dental tobacco control, randomized clinical trial, practice-based root canal treatment effectiveness, assessment of caries diagnosis and caries treatment, case control studies of osteonecrosis of the jaws, retrospective cohort studies of osteonecrosis of the jaws, reasons for placing the first restoration and permanent tooth structures. That was a great study because the Scandinavians brought us in a completely different perspective, and like I say, it changed the way I practice. Reasons for replacement and repair of dental restorations, patient satisfaction with dental restorations, assessing the impact of participation in practice-based research and clinical practice in patient care. I know it's changed me, and probably the rest of you out there, probably it's changed the way you practice also. And the prevalence of questionable occlusal caries lesion. Again, as of February 2010, these are in the data collection phase. The blood glucose testing in dental offices Don alluded to. Again, the Condor study has been completed in gathering data. Development of a patient-based provider intervention for early caries management. Again, a longitudinal study of dental restoration placed on previously unrestored surfaces. And a longitudinal study on questionable occlusal caries and lesions, and a longitudinal study on the repair and replacement of dental restorations. Approved by the PRC, but not in data collection phase yet, is the hygienist internet tobacco cessation randomized clinical trial, and a perioperative pain and root canal therapy. I'm just myself, I'm the tester or trial tester for private practitioner on this thing. Very interesting, a lot of data, kind of a hard one to do though. And going on, persistent pain and root canal therapy and the incidence of postoperative infection after oral osseous surgery. Again, this is just kind of a summary of where we are and up to date of the 16 dental PBRN studies. I'm not going to read through all these for you, but it's interesting. If you look down the center aisle there, the total of practitioners or investigators includes 3,152. And then on the far column there, the number of patients, procedure, other entities, it's 84,415. So obviously there's a lot of doctor-to-patient interaction going on in the research studies, which again, hopefully will change patient care into the future. Here's our website. Again, it's very interactive. You can go there and kind of see what we're about, what we're doing. You can go there and play and that type of thing. And I know I go look to your guys' website too and see what you're up to. Again, thank you for having me. It's a pleasure to be here with you. I'd love to meet any of you, and feel free to come and speak to me after the conference. Thank you.
Good morning, and I too want to thank the President Network for inviting me to come over here. Based on all the accomplishments that you have here, I'm sure that we can take back some of the successful methods you've used here. Well, first of all, the PEARL network. PEARL stands for Practitioners Engaged in Applied Research and Learning, PEARL. Now, Jack, I was told that I only have 15 minutes, so I think I can do it, and I can give 5 minutes to Dom Zero. Is that all right? Okay. These are our current PEARL studies. I'll discuss some of them in more detail as we go along. Number 7, which is the non-carrier cervical lesion treatment outcomes, we're very excited about. It's actually a randomized clinical trial. I usually have, when I do these things, I have sort of notes. But Justin said that I couldn't do them today, and my notes are very important because they have all my jokes in it. So this is The first study is the Deep Caries Treatment Survey. If pulp exposure is expected, 62% of our network would be removing all caries. 18% would partially remove caries, 20% would initiate endodontic treatment. So having done this, we actually published the results in the Journal of the Academy of General Dentistry, and led us to the Deep Caries Treatment Outcome Study. Currently, as of March 1st, 2010, we have 142 patients with 163 teeth. Now that looks pretty good compared to what we had here last year. Last year we had a total of 32 cases enrolled, and we thought that we better make some modifications, so this is what we did. Like this group, we also recruited people in community health centers, and they've been a great source of our participation. We also got involved in modifying our original protocol to be more inclusive, because the class 1 deep lesion, a lot of our practices did not have those kind of patients, so we allowed class 2s to be included in the plan, and we also included recurrent caries rather than just new caries. And thirdly, and also probably importantly, we increased the compensation. So the treatment of deep caries, the aims are to compare the effectiveness between complete and partial caries removal in deep class 1 lesions for maintaining tooth vitality at 6 months post-treatment. Assess the effects of deep caries treatment on patients' post-operative hypersensitivity and oral health-related quality of life. Evaluate direct and indirect pulp capping as well as cavity lining and bonding techniques for non-vitality outcome trends in order to design a follow-up prospective intervention study. So we've basically made three steps here. The survey was the first, this would be the second, and a potential clinical trial would be the third. The present inclusion criteria include that, as I said before, that we now have included recurrent class 1 and class 2 caries. The radiographic depth of the lesion must be greater than halfway the distance from the DEJ to the pulp. Resin-based composite or amalgam restoration would be the choice of treatment. The original protocol only allowed for resin-based restorations. The tooth must be vital and in inclusion with a natural tooth. This is our study decision tree. The tooth has to be vital. The proximity to the pulp is as I explained. We expect to rank the caries activity and then make the decision to either have a partial or full complete caries removal. And the decision to make the complete caries removal would allow either a direct pulp cap, a partial pulpotomy, or endodontic treatment. The partial caries branch allows for the indirect pulp capping or the partial caries removal technique. Now, the 32 cases that we had last year, 20% of them actually were partial caries removal cases, and that was pretty consistent also with our survey. Most of the work on the partial caries removal technique is done in the literature, was done by Edwina Kidd, Mertz, Fair, Hurst, Ribeiro, Maltz, and Foley. So we base our treatment on those documents. The baseline findings of the treatment of deep caries include the mean age of the patient was 22 plus or minus 12 years. Molars comprised 78% of the treated teeth. 8% of the teeth were pulp capped, and of these 60% with calcium hydroxide and 20% with resin-modified glass ionomer or glass ionomer. The remaining remaining caries was 32%, which is a lot higher than we had anticipated. And as I said, both the survey and the initial study was about 18 to 20%. Indirect pulp capping indicated in 41% of the teeth. Liners were placed in 82% of preparations, and of these, 84% were, again, resin-modified glass ionomer and glass ionomer cements, and 15% calcium hydroxide. So that is one of our big studies, and we hope that it will continue. The next study I'm going to describe is the postoperative POH after class 1 restorations. The specific aims here were to determine incidence and severity of POH at 1, 4, and 13 weeks post-op, measure associations between POH and restorations with length and depth, which is the volume, dentin caries activity, lining and bonding materials, restorative materials, and techniques. We closed this study as of November of 2009. We had a total of 613 patients and 682 teeth. At the baseline visit, caries activity was measured according to this scoring system. The depth of the preparation was measured so that we could actually have a volume statistic and relate that to the POH. This is the distribution of the caries activity ranking, which is the first two are the active caries. There was no correlation between active caries and POH, or appreciable hypersensitivity. The second one was the lesion visibility on X-ray. Again, there was no direct relation between visibility on X-rays and POH. These are some of the conclusions of this study. As I said, we just completed them, and they should be probably published and presented at our annual meeting in April. Substantial appreciable hypersensitivity at baseline in teeth with minimal to moderate lesions. About 50% of the hypersensitivity was reduced by restoration. 14.5% with no baseline appreciable hypersensitivity had appreciable hypersensitivity at 1 week, which was reduced to 10% at 4 weeks. We asked our PIs to describe the restorative techniques. Interestingly, the layer technique was used by 65%, whereas most of us, I think, were under the impression that the prevailing school of thought would be layering rather than bulk packing. The RBC restorations only partially reduced appreciable hypersensitivity as compared to baseline, with over 18.9% of teeth reported to have appreciable hypersensitivity at week 4. This is why we took the measurements, the depth and the volume. Cavity depth and volume were not related to AH at weeks 1 or 4. The use of a cavity liner, calcium hydroxide, or resin-modified glass ionomer did not significantly reduce AH at weeks 1 or 4 compared to DBA alone. Self-etch and total-etch DBAs were not significantly different with regard to AH at week 1 or 4. So it seems that the technique is a critical factor. Some offices has had appreciable hypersensitivity as high as 45%, others as low as 5%. So full evaluation of the effects of the restorative materials and techniques depends upon further analysis. The next study is the current status of our endodontic treatment outcomes. We have 1,206 patients at 84 sites. We examined outcomes of endodontic treatment and restoration of teeth 3 to 5 years post-procedure. This is the, I guess, the failure rate due to endodontics. 3.8 were extracted, 2.1 needed retreatment, and 3.4% were pain and percussion. We have a study that was published in the Journal of Endodontics by Lazarski, where his failure rate based on insurance database is 5.6%. So the total failure rate, when you include restoration failures of 3.9 years, which 5% restoration was replaced, 6.4 restoration needed replacement, and 0.4 cracked. So it's 11.7%. So the combined failure rate in endodontic restorative was 20.8. The next one is the Pearl clinical studies that have to do with analgesics. This is still in process. The specific aim was to document the dentist's post-procedural prescriptions and recommendations for analgesic medication, and B, the effectiveness of these medications and side effects associated with their use as measured by patient-reported outcomes. We have 1,938 patients at 53 sites, so we are a little bit more than halfway there. This is the randomized clinical trial I was telling you about. The options here would be the chemoactive dentifrice as one option, the dentin bonding agent with sealants, and then thirdly, the flow ablation-based composite restoration. We have 172 subjects enrolled, and we're aiming for 300. So the total enrollment as of March 1, 2000, in our network is 4,069 patients, subjects, at 94. Our numbers in terms of our are really a lot smaller than your group. We hope to, of course, increase that. So, okay, that's what I want to present today. Thank you.